Hello and welcome to another podcast from Model Technology. Today we're fortunate enough to be talking to Professor Gordon Wishart. Hello, Professor Wishart.
Yeah, thank you for asking me to join your podcast. Looking forward to our discussions.
Perfect, thank you very much. Professor, I was wondering if you wouldn't mind telling us a little bit about your background, your professional background, and how you ended up doing what you are today.
Yeah, I mean, it's quite a long journey. I started at medical school in Edinburgh. I grew up in Edinburgh. As a medical student, you get exposed to lots of different surgical specialties. So I quite like the idea of doing surgery. But actually, rather than training in Edinburgh, I went through to Glasgow. Glasgow is much more like a mini London. Lots of big teaching hospitals and then another 20 hospitals within 20 miles. So a fantastic place to train. I also did a higher degree. I did a research degree in drug resistance to breast cancer drugs. And there were, even back then in the kind of mid-80s, there was a really strong multidisciplinary breast cancer team that to me seemed to make really good decisions about the treatment people should have after surgery. So that's a very long time ago. A lot of places took a long time to catch up with that. But I was inspired by David George, who was the professor of surgery, Stan Kay, who was the professor of oncology, and when he left Glasgow, came down to the Marsden in London. So I really was inspired by these people. And then so I finished my training in Scotland by 95, I think. And Scotland's quite a small place, and there wasn't the type of job that I wanted. So I wanted essentially an NHS job with a strong research interest. There wasn't going to be one coming up in Scotland, so I came down south. I took my first consultant job in Sussex, and then 3 years later, I moved to Cambridge to join up with someone I had trained with in Glasgow. And at that time, Andrew Bradley came down as the new professor of surgery in Cambridge. So Cambridge was an interesting place at that time in 95, a huge multidisciplinary breast cancer team. But the surgeons that we took over from didn't speak to anybody else. So they were very much the old-fashioned type of surgeons. They thought they should make all the decisions. And so it was very easy to turn around and just bring everybody together. And I think between then and when I left in 2010, we did a lot of really good things. We did a lot of clinical research, and that's remained a kind of really strong part of my whole career. I like to change things. Most of the biggest developments in cancer are not laboratory based, they're clinically based. But it's actually much harder to get funding for clinical research, you know, how you change the processes, how you diagnose people more quickly, how you get people diagnosed at an earlier stage, that kind of clinical type of research. Very hard to get funding for it. So you often just do it as a matter of course, do it as part of your job. I'm not saying laboratory research is bad, but you know, a lot of the big developments. So for instance, in 2010, we were using an American system called adjuvant to decide after surgery for breast cancer, who should get chemotherapy. What were the absolute survival advantages of the different treatments? But we thought we should be building our own UK model. So we used cancer registry data, and we built a model using data from the east of England, and we tested it on data from the West Midlands. At the time, they were the two best breast cancer registries for data acquisition. So we launched that in 2010. It's now freely available to patients and clinicians all over the world. Millions of people have used it. It had about 40,000 visitors every week. And we just released a new version of it with more modern survival data. So that's the kind of thing you can, you know, that there was hardly any funding for that. And it was actually all built just with people wanting to do it, to make a difference, to be able to change things for the better. And so that stood the test of time. We've got all these genomic profile tests coming in now, but actually they have to be compared against what is freely available worldwide. So I suppose I've always been interested in trying to change things, make things better, ask questions. Why are we doing it this way? Why don't we do this? And I'd like to think that lots of people that I've worked with have also been influenced to do things in that similar way.
All right, tell me, what are you doing now?
In 2015, I founded a company called Check for Cancer. And the idea started really with trying to do two things, to promote early cancer detection, either by offering validated, evidence-based cancer screening tests. You know, at that time, we had national screening programs for breast cancer, for cervical cancer, and then bowel cancer came on board. But there are other cancers you can screen for. They just hadn't been introduced at that time. You know, we can do this much better in the private sector. So we set up a national network of one-stop breast clinics. So we persuaded the insurers that if they worked with us, we could make sure their insured members got to the right clinic where they would have all their tests done on the first appointment and either be reassured or diagnosed with cancer as quickly as possible. And we still do that today with over 80 breast surgeons throughout the UK. So I think what I was trying to do was improve clinical governance in the private sector. And we started with breast cancer. We've done something similar for skin cancer now, and I'll come back to that because we're now introducing new technology to enhance our teledermatology pathway, and we've done it for prostate cancer. So very much cancer screening, cancer diagnostics. More recently, we've been looking at cancer risk assessment because that's really important for all kinds of things. And then we do cancer genetics as well. So I'm in this privileged position of being the chief medical officer, but also the CEO. I wear two hats. But I think one of the things that has really led to our success is we've always put clinical before commercial. Commercial is hugely important. We've got shareholders. If you do it that way, I think it might take you a bit longer to be successful, but then you have a much more resilient company because it's evidence-based and you know, you gain people's trust and then they tend to keep working with you. So that's been a successful formula for me and for the company.
Can you tell me something about your negotiations with the private health providers in the UK when you were doing that initially? Was that a difficult conversation to have?
It was a really difficult conversation because the private providers didn't really know who we were. They saw us very much as a threat. And actually, because we had to engage with the breast surgeons for our first pathway, the rest of the pathways just followed a similar pattern. And so we now find ourselves in this niche position between the insurers and the private health providers. But actually, it's a win-win for everybody, and especially the patients, because they get access to streamlined best practice pathways. And so, and if you do that, they're often cheaper pathways. So that's good for the insurer. And we tend to send the right people to the right clinic. So that's good for the providers as well. So I see it as a win-win situation.
You also talked about early detection of cancer. So let's talk about breast cancer. Early detection of breast cancer obviously improves the likelihood of a good outcome. But how does a patient get to you from a mammogram to you? Can a person have a private mammogram? Exactly how does the pathway work?
Yeah, so if someone wants to do breast screening with us, we offer breast screening for women aged over 40. And very often these are people who've got a family history of breast cancer, maybe not strong enough to get access to the NHS programme at a younger age. Or they might just know someone who's had breast cancer. They might just be concerned that they're at higher risk. So we can actually arrange their mammogram. So these are done in all the various health provider hospitals and clinics. And then, you know, we get the result and then we help them manage the result.
The mammogram is done in the public system or the private system?
In the private system. And then once they have the result, if it's abnormal, we will call them, discuss the options with them, which will be essentially going back via their GP into the NHS, or if they're insured or want to pay, then they can be seen in one of our one-stop breast clinics, and then the next set of investigations are carried out.
So in the one-stop clinics that you're describing, you do mastectomies, you do lumpectomies in those clinics?
No, they're purely diagnostic. So
okay.
we've taken a decision as a company that we will take people up to the point of diagnosis. And because we vet all the consultants that we work with, and we do that annually and keep an eye on how they perform, then the patient will just stay with that consultant and have a smooth transition into the treatment part of their pathway.
Okay, so the surgeon will then take them into the theatre and perform a procedure as such.
Yeah, so these are just outpatient clinics where we do these tests, and we can see people quickly. You know, we've had people traveling, you know, hundreds of miles just to be seen the same evening, but in general, we can see people in 2 or 3 days, and it's that quick access. And the vast majority, of course, have the investigations and are reassured they don't have cancer. But that's equally important because this is a very worried group of people coming to these clinics.
Absolutely. Tell me, if are you using diagnostic tests that aren't readily available in the National Health Service?
Not really. The one-stop breast clinic will be taking place in the NHS. I would say probably in an ever-dwindling number of locations, but there are still one-stop breast clinics in the UK. I think the one area where we slightly are different is in lung cancer screening. So there hasn't been a lung cancer screening programme, a National Health Service one in the UK. It's planned to be introduced with low-dose CT scans in the next couple of years. They're just doing pilot studies just now to try and make sure they can work out how best to target people aged 50 plus who have a strong smoking history or a family history. But for the last 8 to 10 years, we've been using a blood test that was actually developed in Nottingham, the early CDT lung blood test. And although that's taken off much more in the US than the UK, it's still been available here. And what we've done is we've used that as an initial triage for people at higher risk. And then about 10% have an abnormal result, and then we arrange for them to have a CT scan. So that means that if someone has an abnormality on the CT scan, they can go back into the NHS. What we've tried to do is, even if we're using newly developed technology that the NHS is, we don't want someone to be in a position where we've told them your test is abnormal, but they can't access the NHS, because then they just fall between the two systems, public and private, and we want to try and avoid that.
All right. Now, Professor, you also described skin cancer. Can you tell me something about that?
Yes. So we've been running a teledermatology service since I think we started with Cigna in 2016. And then it really took off when we launched it with AXA in 2018. We were trying to tackle two main issues. Firstly, long waiting times to be seen if you had a suspicious skin lesion in the NHS and the private sector. Waits of up to 10 weeks to see a dermatologist or a plastic surgeon. So that's the first thing we were trying to tackle. The second thing was a really high rate of unnecessary biopsy. So you can imagine you've waited 10 weeks to see someone, they've allocated some time to you, and they say to you, it doesn't really look that suspicious, but we might as well remove it while you're here. That we might as well remove it while you're here might cost £2,000 to the insurance company. You know, it's a lot of money. So we decided we'll run a nurse-led service so that we control the waiting time. We can see people within a few days because we employ the nurses. They will take the history and take the high quality images that you need. They're then uploaded to our system for teledermatology reporting, and we're very lucky we've got two outstanding teledermatology reporters who've been doing it for many years, who have a research interest in skin cancer. So the results we've got from our teledermatology pathway have been excellent. And out of everybody that comes into the pathway with a suspicious lesion, only about 20% have to go on to a face-to-face examination and possible biopsy. We know that particular pathway saves a few £100 for every person that comes through it. It's great for patients. It brings the waiting times down. And actually, when you look at our ability to detect melanoma at an early stage, 96% of the patients diagnosed with melanoma in that programme are diagnosed at stage 1 or 2, early stage. That's much higher than the NHS averages for men or women. That's a very successful pathway, but it means that we've built up all of these images over the last 5 years. We've got about 100,000 images. We've got all the clinical data associated with those images. And that's what makes us different from a tech company just buying the images from somewhere and trying to build an AI model. We've actually got all the clinical data. So 2 years ago, we got 2 grants from Innovate UK. We're building an AI model with a research associate and the University of Essex with 3 senior academics. And we're building an app to take really high quality images that people can take at home that we'll release later this year to give people an alternative to coming to a face-to-face clinic. The results from the AI model, we've only been doing it 15 months now, I think, are just outstanding. And the clinical information makes a huge difference. So we're just going through all the regulatory stuff with that just now, you know, looking at patents, and it'll probably be at least 18 months before we get, you know, regulatory approval to actually launch that in the UK and beyond. But we're very excited about that. But that's just a good example of, if you set something up really well, you collect the data, you can then move on to do something different.
Professor Wishart, you've also talked about prostate cancer. Can you tell me something about that?
Yeah, so prostate cancer is one of these difficult things. You know, the PSA test is such a divisive test. You know, you either hate it or you love it. And actually, when you go and look at the data, the prostate cancer screening, you know, significantly reduces the deaths from prostate cancer. The data is probably more believable and better than for breast cancer. The case is stronger than for screening for breast cancer. But the thing that's always got in the way is the fact that if your PSA is raised, in the old days, everybody went on to have a biopsy of their prostate gland. That was usually done blinded. It wasn't done with any image guidance. So it was very random. A lot of these people, because the biopsies were done per rectum, you know, a lot of people got infection or pain. Some people got really bad infections and could get impotent. So the thing that's changed all of that is that MRI scanning of the prostate gland came in. So if you take someone with a raised PSA now and you do an MRI scan, it tells you whether there's anything abnormal there or not. It allows you to target the exact area where the abnormality is with your biopsy, and it reduces the unnecessary biopsy rate by about 25%. So we've now got a good way of working for men with a raised PSA. I'm not saying that there's, you know, that's going to be the end game in prostate cancer screening. We're hearing that we might have 15-minute prostate MRI scans coming in within the next few years. I've been speaking to an Israeli-based company who have got a fantastic setup where they've actually trained rats to be able to smell the urine and decide whether someone has prostate cancer or not, and the same with lung cancer. So it's, you know, there's all kinds of developments going on. I think there'll be other urine tests for prostate cancer. So, you know, we've got all of these things being developed. So I think it's looking much better. And I think for all screening, we need to move from population screening, where we assume that by the time everybody reaches 50, for all women that reach 50, they must have reached a certain level of risk for breast cancer. Therefore, we'll just screen anybody over 50. So we need to move from that population screening to personal screening. Because if a woman reaches that same risk that most people are at 50, at 35, then we should start screening much earlier. So we need to be using both, you know, questionnaires, genetic testing, to try and work out someone's personal risk for a specific cancer, and then have a screening program that kicks in when they reach that personal risk, whatever age they are.
That was perfect. Thank you very much. Professor, is there something that you're passionate about and want to describe to people?
I think the thing that I'm probably most passionate about at the moment is that 40% of cancers are preventable. Okay. Most of the huge increase in incidence in common cancers like breast, bowel, lung, prostate cancer, well, no, I'll take prostate cancer out, but breast, bowel, lung cancer, they are being driven by Western lifestyle, poor diet, alcohol, smoking, lack of exercise. And you can see it's a global phenomenon. It's not just in the UK. And it's also what's driving cancer being diagnosed in the under 50s as well. So on that basis, we need to be helping people identify those lifestyle risk factors, and we need to be trying to encourage them to mitigate those risks, to take more exercise, to have a more balanced diet, you know, to lose weight, to stop smoking, to drink less. Because actually, we can have the biggest impact by focusing on that early part of the cancer pathway. And if we do that, then we'll stop some people getting cancer. We'll probably pick up some cancers really early if we target those at highest risk for screening. And we can save a lot more money than we're spending at the other end when people are presenting at a later stage. So I think I'm really passionate about trying to get people to focus on that early part of the cancer pathway.
If people want to make contact with you, how do they do it?
Yeah, I'm very easy to get hold of on LinkedIn. I think that's the best way.
That you want to bring up to anyone's attention?
Yeah, I think I mentioned something about an Israeli company.
You did.
They're doing that stuff with lung cancer just now, but they're going to go on to do it with prostate cancer.
Okay, so with the lung cancer, is that a breath analysis they're doing?
It's a urine. So that they're training the rats to smell the urine. I mean, it's not just in somebody's kitchen. It's in a proper laboratory setup. But they're getting sensitivity and specificity of about 90%.
Wow. Okay, that's amazing.
So and what I'm encouraging them to do is they're interested in doing this is to have a multi-cancer urine test, because that would be a great simple way to triage people. It could be a home test where you look at common cancers. So I think we're going to see many more things coming along, but it's just because they're detecting volatile compounds that are cancer related but are appearing in the urine, and the sense of smell of some animals is just phenomenal. So
I was not aware of that, but thank you very much for that.
Yeah.
And thank you very much again for your time today. It's been fabulous. I'm a big supporter of on LinkedIn. I often share your posts, and I talk to people a lot about you. I think you're an amazing individual, and I think what you've achieved is great for many, many people in the United Kingdom and elsewhere. You're a good role model. So I wanted to thank you very much.